You know that feeling, right? That sudden wave of nausea just builds and builds until, well, yeah. Today we're going to take a really close look at what happens when that sort of forceful pressure causes a specific issue in the upper gut, Mallory-Weiss syndrome.
Exactly. We've got your notes right here, and the mission today is basically to pull out all the key stuff about Mallory-Weiss MWS. You'll hear it called, so you can really get your head around it for revision.
Okay, got it. So just in simple terms, MWS is about these small tears in the lining, the mucosa, right where your esophagus joins your stomach.
That's the spot. And it usually happens because of really severe vomiting or, anything that jacks up the pressure there suddenly.
And the big clue, the thing that often flags it up, is vomiting blood.
Right. Hemetemesis. It's interesting, actually. Mallory and Weiss first described this way back, 1929, I think. They saw it in patients who were vomiting excessively, often linked with heavy alcohol intake.
Wow, okay, so that observation holds up.
Pretty much. Our understanding's obviously way deeper now, but that core link was spot on.
Okay, so let's nail down the definition then. Mallory-Weiss syndrome. It's these mucosal tears, lacerations, upper GI tract, typically right at that gastro-oesophageal junction.
Exactly. And like we said, the #1 cause, usually that really severe, maybe prolonged vomiting.
Leading to hemetemesis, vomiting blood.
Yeah.
And you mentioned the pressure link again, heavy alcohol use being a big one.
Yeah, it's definitely a key association. Anything that significantly ramps up that intragastric pressure. Alcohol is kind of a double whammy, isn't it? It can irritate the stomach, make severe vomiting more likely.
And then the vomiting itself does the damage.
Precisely. Creates the perfect storm for a tear.
Right. So what's the actual mechanism, the etiology, the why behind these tears?
Well, the main driver, like your notes really emphasize, is that forceful or maybe repetitive vomiting. Think about the physics of it all, that pressure building up in your abdomen, then expelled violently. It puts this massive strain right at that junction.
Yeah, you can almost picture it. And this isn't just feeling a bit sick, is it? This is proper forceful retching.
Oh, absolutely. Serious force involved.
And the alcohol abuse link, how exactly does that contribute to the tearing?
Well, it's a really common factor, like we touched on. It can directly irritate the stomach lining. That irritation can then trigger that really severe vomiting reflex.
Which ups the odds of a tear happening.
Exactly. Increases the likelihood significantly.
These notes also mention hiatal hernia. That's where a bit of the stomach pushes up into the chest, yeah. How does that make things worse?
Spot on. So with a hiatal hernia, the pressure dynamics during vomiting change a bit. You get this greater transmural pressure gradient inside the herniated part.
Okay, break that down a bit.
Think of it like the pressure difference across the stomach wall. In the bit of the stomach sticking up into the chest, the pressure difference is much higher during vomiting. So that specific area is more vulnerable to tearing.
Like stretching a weak spot on a balloon more.
That's a great way to put it. Yeah, it's under extra stress right there.
Makes sense. And it's not just vomiting, is it? Notes mention other pressure spiking activities.
Yeah, that's important. Anything causing a sudden big jump in abdominal pressure could potentially do it, even if vomiting isn't the main feature. Think about like really violent coughing fits or straining really hard, on the toilet, or even just really forceful hiccups, believe it or not.
Wow. Okay. So definition, causes. Now, who's more likely to get this? What are the risk factors we should be looking out for?
Right. Let's group them. Makes it easier. First up, and it's a big one, is excessive alcohol ingestion. That really does stand out.
Yeah, keeps coming up. What else puts someone at higher risk?
Then there's a whole bunch of conditions that just make people more prone to retching and vomiting. It's quite a list, actually. Things like gastroenteritis, your standard stomach bug.
Okay.
Hyperemesis gravidarum, that's the really severe morning sickness in pregnancy. And the notes actually say that's the most common cause in women of childbearing age.
Huh, that's really important. So it's definitely not just about alcohol.
No, not at all. The list goes on. Bulimia, kidney disease, raised intracranial pressure, various biliary problems like gallstones or cholecystitis, hepatitis, even migraines, cyclical vomiting syndrome, gastrointestinal obstruction too, and certain meds that can make you vomit, like some chemotherapy drugs. So yeah, loads of things can unfortunately set off that severe vomiting trigger.
That's a really wide range of vomiting triggers. And the notes also brought up chronic coughing again.
Yep. Conditions tied to long-term or really severe prolonged coughing spells. So you're thinking COPD, maybe lung cancer, bronchiectasis, whooping cough, even just bad bronchitis. All that forceful, repeated coughing puts a lot of strain on the upper GI tract.
And we can't forget the hiatal hernia we talked about. Notes mention that again as increasing risk.
Precisely. Then you've got some less common, but still relevant risk factors. Things like blunt abdominal trauma or even CPR cardiopulmonary resuscitation can increase pressure down there. And there are rare iatrogenic causes, basically, tears happening because of a medical procedure, like, say, during an upper GI scope. That's pretty uncommon.
What about medications? Any others?
Yeah, aspirin and other NSAIDs are mentioned as potential risk factors sometimes, probably because they can irritate the gut lining.
Okay.
And finally, it's worth remembering that sometimes you do all the tests and you just can't find a specific cause. Those get called idiopathic cases.
Okay, so we've got the what and the who. Let's dig into the how a bit more, the actual sequence in the body, the pathophysiology.
It's actually fairly straightforward mechanically, like we've been saying. You get this elevated intra-abdominal pressure during that forceful vomiting or whatever the trigger is.
Right.
That sudden pressure surge causes the tiny blood vessels near the gastro-oesophageal junction to rupture, and it's the rupture of those vessels in the mucosal lining that causes the Mallory-Weiss tear. Think of the force like a sudden water hammer in a pipe. If there's a slightly weaker spot, those delicate blood vessels, bang! The pressure causes them to burst. That's your tear and you're bleeding.
That makes sense. Pressure finds the weak spot. Okay, so someone comes in vomiting blood. Mallory-Weiss is on the list, but it's not the only thing it could be, right? What else are doctors thinking about?
Oh, absolute critical point. That's the differential diagnosis. So besides MWS, you have to consider things like peptic ulcers. They're a super common cause of GI bleeding.
Right.
Esophageal varices, those enlarged veins in the esophagus, especially important if the patient has liver disease. Gastritis, just inflammation of the stomach lining, can bleed too.
Okay.
Then there's a more serious one called Borhav syndrome. That's a full thickness rupture, a hole right through the esophagus, much nastier.
Wow, okay.
And then, various other maybe less common causes of upper GI bleeding need to be kept in mind.
Got it. So MWS is one piece of that diagnostic puzzle. Now, how common is this? Let's talk epidemiology, specifically in the UK.
Okay, so the notes suggest the incidence here is somewhere between 84 and 170 cases per 100,000 adults each year. So it's not super rare, but maybe not the most common thing either. Clinicians will definitely see it.
And a typical age range?
Usually hits people between 30 and 50 years old, but important note, it can happen in kids too.
Right. And the alcohol link, again, does that drive the numbers up?
Yeah, definitely contributes to the prevalence. That pattern of alcohol abuse being a significant factor is pretty consistent in the data.
What about the overall outlook? What's the mortality rate?
The notes quote it as being between 7 and 14%, but that needs context. Often the tear itself isn't the main issue, it heals. The mortality is more often linked to how bad the bleed is, or if the patient has other serious health problems.
Okay, that's important context. And how does MWS stack up against all upper GI bleeds?
It accounts for about, 4 to 8% of them, according to these notes. The big player, the majority cause of upper GI bleeds, is actually peptic ulcers. So MWS is significant, yes, but ulcers are more common overall.
Good perspective. Okay, so we know what it is, how it happens, who gets it, how common it is. What does it actually look like when someone presents the clinical features?
Well, the absolute hallmark symptom, as we keep saying, is Hyperemesis, vomiting blood. And the key thing is it often follows a bout of really forceful retching or vomiting first. So that history, severe vomiting, then blood, is a massive clue.
Okay, that sequence is vital. Any other signs of bleeding we should look out for?
Yep, definitely. Patients might also have melena, those black tarry stools.
Right, indicates digested blood.
Exactly. Or sometimes hematochezia, which is bright red blood in the stool. That usually means lower GI bleeding, but you can sometimes see it with brisk upper GI bleeds too.
And how might the person feel generally, apart from the obvious distress of vomiting blood?
Well, depending on the blood loss, they might feel lightheaded, dizzy, maybe even pass out syncope. That's all due to the drop in blood pressure from losing volume.
So, potentially quite unwell. Is there anything specific a doctor finds on examination, like listening to the chest or pressing on the tummy?
Interestingly, no. The notes are clear. There aren't usually any specific physical signs that scream Mallory-Weiss. The diagnosis really hinges on the story, the history the patient gives, and then what you see on endoscopy.
Okay.
But what is crucial on examination is assessing how severe the bleed is. That's where things like the Rockall score or the Glasgow-Blatchford score come in. They help quantify the risk and guide how urgently you need to act.
Right, those scores are key for management.
Yeah.
So how do we actually confirm it's MWS? What investigations nail the diagnosis?
The gold standard, the main tool, is endoscopy, specifically an esophagogastroduodenoscopy, or EGD.
The camera tests.
Exactly. Flexible tube with the camera goes down, lets the doctor look directly at the esophagus, stomach, first part of the small bowel. They can literally see the tear, see if it's actively bleeding, assess the size.
So direct visualization is key.
Yeah.
What about blood tests? Are they helpful?
Oh, absolutely vital. Several blood tests give crucial info. You need a full blood count, FBC, and hematocrit to see how much blood's been lost and track it over time. Coagulation studies, platelet count check for any clotting problems that might make bleeding worse. Renal function urea, creatinine, electrolytes guides your fluid replacement and tells you how the kidneys are coping.
Right.
And of course, cross-matching, or group and save, with an antibody screen. Essential if they need a blood transfusion. There's a handy mnemonic here, actually. Funky cats really eat apples.
Okay, funky cats really eat apples.
Okay.
FBC.
Coagulation, renal function, electrolytes, antibody screen helps you remember those core bloods.
That's useful. Any other tests sometimes needed?
Yeah, in certain situations. If you're worried the bleed's putting strain on the heart, you might do an ECG and cardiac enzymes. And if the bleeding's active but you just can't pinpoint it with the scope, sometimes angiography is used that's imaging the blood vessels with contrast dye.
Okay, got it. So diagnosis confirmed. What's the management plan? How do we treat Mallory-Weiss?
First things first, always is resuscitation, especially if they're unstable or have lost a lot of blood. Think ABCs: airway, breathing, circulation.
Standard emergency approach.
Exactly. High flow oxygen, get good IV access, big cannulas for fluids, potentially blood transfusion if they've lost, say, around 30% of their blood volume or meet criteria. Follow your local major hemorrhage protocol if it's severe.
Right. Stabilize first. Then the endoscopy is diagnostic, but you said it can be therapeutic too.
Yes. Ideally, you want to do the endoscopy within 24 hours. Quick note. Generally avoid PPIs before the scope, as they can sometimes obscure the tear a bit.
Okay.
Now, the good news is most MWS tears actually stop bleeding on their own, spontaneous resolution. But if it is bleeding persistently when they scope, then yes, they can treat it then and there.
Oh, what do they do?
Couple of options. They can apply little metal clips across the tear to hold it closed, or use thermal coagulation heat to seal the bleeding vessel, or inject stuff like thrombin or fibrin with adrenaline right at the site to help clot formation.
Wow, quite a few tools in the endoscopic toolbox. So what happens after the scope?
Okay, post-procedure, you calculate the full Rockall score. A low score, maybe less than 3, suggests lower risk of it bleeding again. Higher score, over 3, they probably need closer inpatient monitoring.
Makes sense.
But regardless, you're watching their vital signs closely, tracking urine output, looking for any signs of ongoing bleeding. For lower risk patients, they might be able to start a light diet maybe 4 to 6 hours after the scope.
And what about that risk of rebleeding? You mentioned higher risk scores.
Yeah, rebleeding is definitely a concern, especially for certain folks. Patients with cirrhosis or kidney failure, or those who had specific features on the first, like active spurting, they're at higher risk. They might need observation in hospital for maybe 48 hours.
Okay.
If the bleeding just won't stop despite endoscopic treatment, then you might escalate to interventional radiology. They can sometimes embolize the vessel, or rarely, surgery.
And when is rebleeding most likely to happen, if it does?
Typically within the first 48 hours, especially if they were shocked on arrival or had active bleeding seen on that initial endoscopy.
Okay, so prompt management, close monitoring, especially early on. What's the general outlook then, the prognosis for MWS?
Overall, it's generally good. Like we said, most cases stop bleeding by themselves or respond well to conservative measures or that endoscopic therapy.
That's definitely reassuring to hear. Are there potential complications, though? Things that can go wrong?
Yes, while prognosis is good, complications can happen. The main one is probably rebleeding. There's also a risk of aspiration pneumonia, inhaling stomach contents if vomiting continues.
Oh, yeah.
And much more rarely, the tear could actually go all the way through a perforation. That's obviously very serious.
And can it happen again? Is recurrence a thing?
It's pretty rare, but yeah, it can recur, especially if those underlying risk factors aren't dealt with, like ongoing heavy drinking or that chronic cough doesn't get managed. So addressing those triggers is key for prevention.
Right.
And it's worth noting, too, if someone has other significant health problems like cirrhosis, that can definitely impact their overall prognosis, even if the tear itself heals.
Let's just circle back on those complications. The notes break them down usefully. Can we recap those categories?
Yeah, good idea. So related just to the symptoms, the vomiting itself, you can get electrolyte problems like low potassium, hypokalemia, we mentioned aspiration pneumonia, rarely perforation or mediastinitis, that's inflammation around the esophagus.
Okay, and then complications directly from the bleeding severity. We had that mnemonic. Shark attack?
That's the one. S for shock, hypovolemic shock from blood loss, H for hypovolemia itself, and R for rebleeding. Remember, rebleeding is more common if they were shocked initially, had low hemoglobin, needed lots of transfusions, or had active bleeding on scope.
Got it. Shark attack.
And severe bleeding can also put strain on the heart, potentially causing myocardial ischemia or even an infarction, especially in someone with existing heart disease.
And what about the impact on other underlying health conditions?
Right. Comorbidities. So like we just said, bleeding could worsen heart issues, potentially trigger an MI. In someone with liver disease like hepatitis, a big bleed could tip them towards liver failure. Same for kidney disease. It could cause an acute kidney injury or worsen chronic kidney disease. And in diabetes, the stress of it all can mess up blood sugar control, potentially leading to serious problems like diabetic coma.
So it can really exacerbate existing problems.
Yeah.
And lastly, risks from the treatment or investigation itself.
Yeah, nothing zero risk. Endoscopy, while generally safe, has rare risks like mediastinitis, aspiration, perforation, or even making the bleeding worse sometimes. Angiography, if used, has its own risks like blocking off blood supply to organs or worsening bleeding. So you always have to weigh the risks and benefits and manage any complications carefully.
This has been incredibly comprehensive, super helpful for revision. Any more of those memory tips or mnemonics that help lock this all in?
Yeah, absolutely. Mnemonics are great. For the definition, remember tears after cheers. Links the alcohol often involved with the actual tears.
Tears after cheers, love it. What about the vomiting-related risk factors, that long list?
Right, got beer, so very rough. That covers gastroenteritis, bulimia, biliary disease, excessive alcohol, renal disease, severe vomiting itself, and raised ICP.
Got beer, so very rough. Nice.
Yeah.
And the differentials, what else it could be? We had pub goes bad.
Exactly. Peptic ulcer, upper GI bleed, other causes. Borhaves, gastritis, esophageal varices, and Mallory-Weiss itself in the mix.
Perfect. These are brilliant for recall. Let's try a quick practice question then. Say a 45-year-old male, history of heavy drinking, comes in with Hyperemesis after lots of forceful vomiting. Most likely diagnosis.
That scenario screams Mallory-Weiss syndrome, and the tears after cheers mnemonic fits perfectly. Alcohol, vomiting, leading to the tears.
Spot on. Okay, one more. Primary investigation to diagnose MWS. Think about needing to see it.
That's got to be the upper gastrointestinal endoscopy, the EGD.
Excellent. Okay, well, this has been a fantastic deep dive into Mallory-Weiss syndrome. So just to quickly sum up, we're talking mucosal tears, usually at the gastro-oesophageal junction, caused by increased pressure, often from vomiting. Hyperemesis is the key sign. Prognosis, generally good.
That's a great summary. And really understanding the causes, the risk factors, how it presents, and those potential complications. That's crucial for managing it effectively. And of course, for nailing it in your exams.
Definitely. And just to leave you with something to mull over.
Yeah.
Given that wide range of things that can increase pressure, what seemingly minor events might actually be enough to cause a Mallory-Weiss tear. Bit of food for thought there.
Absolutely. And look, if you are revising for the MSRA and want more resources like this, really in-depth stuff, head over to passthemsra.com.
And for loads of great free learning materials, check out freemsra.com as well.
Definitely worth a look.
Brilliant. Well, thanks so much for joining us for this deep dive into Mallory-Weiss syndrome. We really hope this has been useful for you.